Good morning. Y'all can welcome Kelly again. She's really excited to be here this early talking about hepatitis.
Oh, I'm still sleepy, I think. Did y'all have any questions from the last lecture at all? Or you can always email me too. I think I put my email on the end. So, well, we'll move on to the liver, and I'm going to talk about the pancreas too a little bit after this. So, hepatitis and cirrhosis. This used to be my thing that I was afraid of the most, but I actually like the liver now a lot more since I've gotten more comfortable with it. But here we go. Maybe. I think it's on now. There we go. So just a basic definition, general vague definition, sort of inflammation of the liver. Lots of different causes for hepatitis, so when you're thinking a person has it, you have to sort of go through the big old list that we'll talk about. Often characterized by jaundice, that's what people think of when their liver is sick. Sometimes fever, sometimes the liver can become enlarged, sometimes more vague symptoms like abdominal pain. You know, I have seen folks with just total asymptomatic disease, so it has to be on your radar. There's different types of hepatitis, and we're going to talk about these. Viral is pretty common. Different types of viruses within that. Most common that we see are the hepatitis A, B, and C, but certainly Epstein-Barr can cause a hepatitis type picture inside a megalovirus. Autoimmune hepatitis, not all that common, but it is something to think about. Toxins, there's lots of things in our environment, medications, that are considered toxins to the liver. So that definitely has to be thought of. Alcoholic hepatitis, that's one you can think of frequently. And non-alcoholic steatohepatitis, so we'll talk about that as well. I sort of broke down how we're going to work up the liver, just so you can have some definitions of lab tests and sort of what they mean and what to think about when different ones are elevated. ALT, alanine aminotransferase, is most specific to the liver. When you see that one elevated, definitely think the liver. And you can use it to follow progression of disease. We use ALT and AST in combination, sometimes look at their ratios to figure out different patterns, but that can also be elevated in cardiac events. So if you're just seeing an isolated AST elevation, it may not be the liver. Alkaline phosphatase is another one we use together with the ALT and AST. It is the highest concentrations of this are found in the biliary tree. So if you just have an elevated alkaline phosphatase, you might think more biliary rather than liver, but it's often elevated in liver stuff as well. Also can confuse you a little bit because it can be elevated in some bone diseases. And so also think PBC and PSC, which we'll talk about in a little bit. Total bilirubin, that can be elevated with liver disease. You can break it down into direct and indirect, or conjugated and unconjugated, sort of to figure out patterns as well. Different elevations mean different things, so you can use those. And we also use not as much a liver function test, but ammonia can be elevated in liver disease. You can have changes in the PTINR, albumin, LDH, immunoglobulins you can use as well for autoimmune disease. So I have a case. It's a lady I saw a long time ago. She had a slight elevation in her LFTs in the past. They would sort of come and go, be slightly elevated, then return to normal. She had a history of some statin use, but in the past, about a year ago, her ultrasound was normal. She presented to her primary care provider. She had some changes in symptoms. She was noticing a very dark urine, and her lab tests were markedly abnormal. ALT was really high, and AST was as well, so they were both up. Alkaline phosphatase was pretty normal. So the bilirubin was 4.6. So then she came and saw us. She was really, not feeling terrible. She had some mild fatigue since starting school. She was a teacher. Some mild nausea, a little bit of a weight loss in the past 6 months, but nothing too extreme. Her current medications, she had been on the statin before, but she'd been off of that. She was only on atenolol. Pretty healthy lady, a little cholesterol and history of tachycardia. She thought her aunt may have had some type of liver disease, but she couldn't remember what. She never used alcohol, not a smoker. No tattoos or drug use. Married lady. Review system was normal. Her physical exam showed a little bit of yellowing of her eyes, the scleral icterus, and some abdominal jaundice. Her labs, again, were pretty abnormal. Her ALT and AST were still elevated significantly. Her bilirubin was 3, ferritin 903. We often look at the iron studies, which we'll talk about in a little bit when we work up liver disease. Her Epstein-Barr viral capsid antigen was positive, or ASMA was positive, but everything else in my workup was normal. Again, our ultrasound at that time looked good, especially compared to a year ago. It still looked normal. The CT and MRCP that we ordered to evaluate that showed some inflammation around the biliary tree. So we'll come back to that. Be thinking about her as we talk about the different diseases. Moving on to the viral hepatitis, hepatitis A. This can be very mild. Some people never know they've had it. So very sick, or they're in the hospital. Some maybe even need a liver transplant if they're very sick. But most people do pretty well. They clear the virus, don't even know they had it. But some can have a sort of a mild relapsing course. Anywhere from asymptomatic to fever, abdominal pain. You might be jaundiced. They might have the dark urine as well, due to the bilirubin being elevated. Sort of virally symptoms that you think of. Transmission is fecal-oral route or sexual contact. Usually it's contaminated food and water, people not washing their hands in the food industry. Sort of gross. Diagnosis is blood work, blood tests for the viral antibody, IgG, IgM, can tell you whether it's prior infection or recent infection, and the treatment is supportive. There's no cure for Hep A. Most people can do well and get rid of it, but just support these people if they're sick. You can prevent, if they have contacts close by, they can do the serum globulins to prevent transmission. Good hygiene is so important. And folks who are traveling to places where this is more endemic, it's important to vaccinate, because there is a vaccine. So it is one that we can prevent. Also, in my chronic liver patients with like cirrhosis, we always want to vaccinate those folks so they don't get accidentally exposed to it and have another injury to their liver. So that's something to think about in your liver patients. Hepatitis B, as Whitney knows, this is my favorite. I really don't like hepatitis B because it's sort of complicated and just not always straightforward, and there's lots of different recommendations. But it is around. It is a common virus. Worldwide, it's very common. U.S. it is as well. And people die of it because it can cause cirrhosis, it can cause liver tumors. The most prevalent areas in Asia, sub-Saharan Africa. And all of my patients with Hep B are actually Asian that have come from like China or one of those areas. But it can be in anybody. You have to think of it. It has an incubation period. It's transmitted perinatally. So it is one to think of with if you're in GYN care, they always screen for hepatitis B and are very aware of that. It can be transmitted sexually. You think of that more with Hep B, but also the needle contact as well, contaminated needles. It might be pretty vague symptoms. You know, the viral symptoms, fatigue, anorexia, some joint pains, and the labs will be pretty obviously positive if you have hepatitis B. You might see some elevations in the transaminases, but the serologies will be positive in certain patterns. Supportive, again, for the acute hepatitis B, get them through their illness if they're sick, just with support. And most people can clear the virus, and they are completely better. Some can convert to be chronic carriers that, again, have no symptoms and normal labs, but their serologies will be positive and indicate that. Moving on, so acute is sort of the acute phase, and then chronic. Some people clear it, but some people are chronically affected by it. It tends to be related to how early on you were exposed to it. 90% of newborns with hepatitis B do develop a chronic infection, so that's why it's pretty important in that mother pregnancy type thing to identify it. So hopefully you can prevent that transmission. People who are more symptomatic tend to be the more chronic disease as well, but you can be asymptomatic and still develop chronic disease. People with chronic hepatitis B are the ones who are higher risk for tumors, even if they don't have cirrhosis. It seems to be like a carcinogenic type effect with hepatitis B virus. Seems to be a correlation between those with higher levels of hepatitis B virus and cirrhosis, and the risk of cancer with higher levels. I hate serologies. I look them up every time, and I still have to work through them. But I swear this is on every test that I've ever taken. I always choose to miss this question because I don't want to put it in my brain. But if you want to memorize it, you can. And they help you sort of decipher where these folks are. It will probably be on the test. I'm telling you, it will be on the test. But it is. I just don't choose to learn it because I can look it up. But for testing, your students, so you have to learn this stuff. So it just helps you tell people where they are. Hepatitis B surface antibody will be positive with vaccination, so that's a common one to remember. The BE antigen, these guys tell you whether these patients are going to be more contagious than others, because if their positive hepatitis B antibody is positive, they're sort of a quiet infection. They're really low risk for transmission. Not that they shouldn't take precautions and things, but they're lower risk. And if you see this positive hepatitis B antigen positive, they're the ones that are going to possibly be transmitting, the disease. So goals of hepatitis B therapy, we'd love to cure it. There's really not a cure. Unlike Hep C, which you'll see that I get really excited about in a minute, there is no cure for hepatitis B. So we're managing these patients and trying to keep them healthy, screen for cancers, things like that, help them not hopefully get cirrhosis. But also, we don't treat everybody. There's lots of different guidelines that tell us when to treat and when not to treat, because sometimes the treatments are higher risk than the disease itself. So we try to, if they're having symptoms, we try to improve those. Suppression of the hepatitis B DNA, if that starts to rise. Sometimes with treatment, people will seroconvert from the more active disease to the less active disease, so that's always a goal. Getting their ALT normal is nice if you can. Getting rid of the inflammation, which is the progresses to fibrosis, so that's always a good thing as well. Mortality, of course, and trying to decrease the spread. That's always important. So educating these patients on how that happens. Here I've said there's lots of guidelines. There's probably like 10 different liver organizations that like to put out their hepatitis B guidelines. So it depends on whose guidelines you look at. There's European societies and American societies, so there's lots of different variability. Elevated ALT at a certain level is when you start considering treatment, and the DNA level at a certain level is another indication. So you have to look at all the guidelines and the patient. It's very individualized as to whether you decide to treat. There's several different out there. Again, there's no cure, but these are antivirals that decrease the viral load. So hopefully there'll be a cure like Hep C. This virus really likes to mutate and change, and I think that's why it's so hard to find a cure. But hopefully they'll come up with something. There's some studies that are looking at sort of combinations of some of those that I listed on the previous slide. Sometimes liver transplant is, the treatment of choice if they have end-stage liver disease. So these people are going to continue to be treated as well because the virus is still in their system, but the liver will be better. Hepatitis D, I've never seen it, but it's out there. It likes to hang out with hepatitis B. There's co-infection and superinfection. I guess when you get hepatitis D, you want to get it at the same time with Hep B, because then they usually go into remission and don't have any trouble. But if you have B and then get D, it makes your disease worse. So just something to think about. Very similar symptoms to Hep B. You have to think of it and test for it to find it. There's no real specific treatment, though, at this point. The B vaccine they have found protects you against D, so that's another reason to vaccinate for the hepatitis B. Hepatitis C I do get excited about. 10 years ago I did not get excited about it because the treatment was not successful and very tough on patients, and it didn't cure them, so it sort of felt like a useless waste of my time. But hepatitis C is curable now, which is really exciting. It is a prevalent disease in the U.S. and worldwide. There's lots of different types of hepatitis C. Like in North America, it's a 1%, but in North Africa, it's 13%, which is a pretty prevalent disease in that area. It's another RNA virus that likes the liver cells. There's different genotypes. So you have hepatitis C, but then you have different types of hepatitis C. So you have to determine that. It seems like different types are in different places as well. You see a lot of genotype 1 in the U.S. Other places in the world, you see different genotypes. Those who've been treated previously seem to be a little harder to treat. With our newer meds over the past 5 years, even the ones that have been previously treated can be successfully treated, which is exciting, because that was not the case in the past. Transfusions, a long time ago, like in the 70s, you might have picked up Hep C from a transfusion. They've been screening for Hep C for years in the U.S. Injection drug use is the biggest risk factor for hepatitis C transmission. Potential needle sticks, in healthcare, you can get Hep C. Sexual contact is lower, unlike Hep B, which is a better way to transmit that. Perinatal exposure is low compared to Hep B as well. So little differences in the viruses. There are a couple little pictures in there to show you sort of the difference. Injection drug use is much more common to pass along Hep C. Some of these folks are coming to me after they were trying to get life insurance, and they're like, oh, I have Hep C. They never knew they were exposed to it or had it. They never had symptoms of it, but their hepatitis C antibody is positive. How long ago, Whitney, was it that they started telling to screen for baby boomers? Is that 5 years, 10 years?
I say 5, but around 5 years.
Sort of one of the screenings that primary cares have been encouraged to do over the past 5 years is to screen for Hep C. People will look and say, there's no way I have Hep C.
You have commercials for it
yeah,
now, too.
commercials, because the treatments are available. So it's definitely people have become more aware of it. But, these folks may never have had any symptoms. They might have had a viral symptom, 20 years ago, and that was their Hep C. Sometimes fatigue. I see that a lot in patients, but everybody's fatigued. Some nausea, depression, maybe abdominal pain. Typically asymptomatic, though. With a more advanced disease, you can certainly present with, decompensated liver disease, with like ascites and encephalopathy, but I don't find that too common. Usually they would have known at some point. Once folks have been exposed to hepatitis C, about 80% will become chronic carriers. But there is 16 to 20% of folks who can clear the virus on their own without any treatment. They're the lucky ones. I tell them they're lucky because they don't have to have any treatment. Their liver's fine. They're not going to have any issues there. But most of them will become chronic, and those are the ones we have to consider treatment and watch them a little more carefully. Like I said, sometimes we see it in donations, screening, routine screening in the stage liver is uncommon, but it can happen the longer you've had the hepatitis C infection. This is just to show you the longer you've had Hep C, the higher risk of complication years after diagnosis when people develop complications. It doesn't happen overnight, but over time it can. And the risk of your hepatocellular carcinoma goes up the longer you've had it as well. They found, how I was saying about Hep B, it tends to become more chronic if you're exposed to it as a baby. It's sort of different. Hep C, age at time of infection, seems to become more chronic if you're exposed to it older. So it's I like to think of these differences. They found that male gender seems to increase your risk of progression to more significant disease. Co-infection, with HBV or HIV. Obese patients tend to do a little worse. My thought there is that they might have a component of fatty liver and NASH too, and sort of, again, two liver diseases together seem to be more severe. Possibly race might play a part in how people progress a little more quickly. Alcohol intake, because you're insulting your liver again with alcohol. They've found that folks who present more with elevated ALT seem to have a more aggressive disease as well. So they're just sort of little predictors. They have found that the genotype, the type of Hep C that you have, doesn't seem to influence your rate of fibrosis, and even the number of virus. People in the 3 millions don't seem to have any more aggressive disease than the ones that have 800,000. So those are little interesting things about it. Y'all probably remember me talking about the extrahepatic or extraintestinal manifestations of IBD. Well, you can have extrahepatic manifestations of hepatitis C. There are some folks who present with these and then they find that they have hep C. I know when people present with the cryoglobulinemias, they're always checking hep C as well, just to make sure that that's not part of it. But there's some others as well. Sjogren's, lichen planus, non-Hodgkin's lymphoma can often be associated with hep C. Porphyria. There's a little chart, some the different extrahepatic manifestations. So when you're diagnosing hepatitis C, the antibody is the first thing most people check for sort of a screening test. That will be positive if you were ever exposed to it. You know, there is that 16 to 20% that can clear the virus, but that hepatitis C antibody will always be positive. So you have to explain that to patients. No, you do not have hepatitis C, but this test is always going to be positive. They're probably not going to let you donate blood, those type things. The viral load is what you use to sort of confirm that hepatitis C antibody is truly positive, because that will tell you. I like the quantitative because that's going to give me a number of how many viruses that's detected. Qualitative doesn't help me a lot because I don't use that much, but you can use that if you want to. Also, the quantitative is used to monitor drug therapy and their response, so you use that number a lot. In the past, we did a lot of liver biopsies. It was often required to consider therapy, whether these patients had enough fibrosis to consider medication. But now we're not using much of that. There is a test called FibroSure, which is a blood test, and it uses different things to measure, sort of predict the amount of fibrosis. It also calculates inflammation as well. So we're using that test a lot when we're trying to get the medications approved. So you want to know hepatitis antibody. If that's positive, move on to the viral load. And then if you're considering, treatment and things, we often use FibroSure. You can still do a biopsy. If you're confused whether it's just hep C, is there another type of liver disease involved? Sometimes that's helpful. So when you're considering which medication to pick, you have to consider the genotype, because not all the meds cover all genotypes, and also the viral load. Most people with hep C we can get medication approved for now because it is such a high cure rate, and it can make a change in their disease and outcomes. But in the past, sometimes the viral load wouldn't be high enough, and they'd say, well, I don't think this person needs medicine. The insurance companies are saying, well, I don't think they need to be treated, or their fibrosis isn't significant enough, so they don't get treatment. I'm like, that's not really fair. I mean, this is going to make a difference in the long run. But they've definitely changed their tune, which is exciting because we can get people cures. And we often monitor the viral load for response and then cure. So therapy, I didn't even try to list the names of the medications. There's lots of them. There's lots of them coming out and changing. It's changing all the time. I use the HCB guidelines a lot. It's easy to use, it makes sense, and you can figure out which is the best recommended course. When the insurance company comes back and says, oh, we don't like that one, and you say, well, this one's just as good, so you can use that pretty easily. UpToDate's good. There's also an app as well that folks are using. Any questions about Hep C? I do love Hep C, so we can fix people. Some other viral etiologies. Honestly, I don't see them that much, but I just want for thoroughness, I wanted you to think of them. Epstein-Barr virus. You can check the labs for the viral capsid antigen IgM for acute infection. Titers to see if they've had it in the past. Cytomegalovirus as well, same type picture. The IgM is positive in the acute infection. And other viruses. We don't have tests for all the viruses. There's only so many that we can check for with the blood. But if all these are negative and they're still sick, they probably have something going on. They could potentially still have a virus causing it. You can rule out other causes. Moving on to some toxins. There's sort of put them in two categories. There's cytotoxic and there's cholestatic that can cause the hepatitis picture. Cytotoxic are affecting the cells of the liver. Usually you'll see a pattern with the ALT greater more than twice up its normal limit, and alkalis is usually very elevated as well. So you can use a lot of patterns. When I have students, we always talk about liver patterns when we see lab work, and you can almost figure it out looking at the lab tests. and how things are elevated, and the history, of course. So some common ones are semi-cyanide, ketoconazole, phenytoin. There's lots of drugs that can cause issues with the liver, though, as I'm sure y'all learn in your pharmacology. Cholestatic picture, the alk-Phos will be a lot higher, or if ALT, the alk-Phos ratio is less than 2. So some different, I've seen augmentin cause that type picture before. I had a lady who was postpartum, and she'd had a mastitis infection, and she was on augmentin, and she got super sick. But she did much better once the medication was figured out and that was causing it. Estrogens, some steroids, anabolic steroids. So those are things that you might see. Chemotherapy and the liver don't get along, a lot of them. Some other common ones you'll see methotrexate, of course Tylenol, amiodarone. See, mushrooms. Tell people not to eat mushrooms. I always do. Sometimes herbal teas. History with these folks with the liver stuff is so key. I mean, these people don't even think that something they're drinking could cause some liver problems. So think of herbals, think over-the-counters. Make sure they're telling you everything they're taking when you have a liver issue. Sometimes industrial exposures. Ask people where they work, what they're doing, what they're exposed to. Because some of the, I don't know all the specific solvents and things, but you have to think of that as a possibility. Alcoholic hepatitis, it's pretty common. Sometimes in the college population as well. But it is just a description, a clinical manifestation of too much alcohol. The definition of 80 grams per day. One person can have alcoholic hepatitis with a lot less, and sometimes it takes a lot more. But that's just sort of a general definition. Usually prolonged use. But one of my colleagues had a lady in her 30s who was drinking like less than 2 drinks a day, and she had severe alcoholic hepatitis and had to have a liver transplant. So it's just so variable. You can't really just say, oh, they're a big drinker. And they're not. It's all how the body will tolerate it. We're also different. So think of it. They may have some fatty issues as well, some inflammation and fibrosis, or they might just have a lot of inflammation. The treatment, of course, is abstinence. That's about all you can do to hope that it gets better. In the past, I just went to a conference this weekend, and they had a talk on alcoholic hepatitis, and I came away from it learning that I don't think there's a lot you can do about it anymore. The studies don't, in the past they've used prednisone for a period of time, and the studies just don't really prove that makes any difference in like 28 days or 6 months. Pentoxephalin was used in the past, so I left them on here. This is question marks. Sometimes these studies will change and they'll change their mind, but I don't really think anything's exciting. Supportive care was the most important thing. Getting these people to be able to eat, to drink on their own, getting their protein and all those things that they need to get better, get them to stop drinking, getting the care, the support they need there. Patients always ask me about milk thistle. I think the evidence is not great. I don't think it's going to hurt your liver, so I think it's okay. Liver transplant is sometimes, the guy who was talking about it this weekend was saying sometimes that's, basically the only thing you can do. A lot of liver transplant centers, though, will not transplant you if you've been drinking in 6 months. So that's another difficult thing to overcome for some of these patients. Are they really committed to making a change? So it's a tough disease. It's pretty sad. Non-alcoholic steatohepatitis. This is sort of the exciting thing in liver disease talks these days. These are the folks who are not alcohol users. If you took a NASH liver and an alcoholic liver and you put them side by side, they look the same. They have these similar changes in inflammation. So you really can't tell the difference on a liver biopsy. But these are often seen in obese patients, diabetics, sometimes people on certain meds. People who have been on steroids for a long time can have this change. It's basically a fat in the liver causes inflammation, and the inflammation causes fibrosis and cirrhosis. So it's sort of like that transition. Often they're asymptomatic. They're usually discovered accidentally. Their primary care has been watching their labs over the past few years, and they've sort of seen a roller coaster. Sometimes they're slightly elevated, sometimes they're normal. They might take them off their statin, thinking it could be that, and it just sort of continues to fluctuate a little bit. Nothing usually sky high. These folks don't have LFTs in the 500s and 600s. This might just be a little bit abnormal. I'll often have patients say, yeah, my doctor told me a couple years ago they were a little bit high, but then they got better. And their ultrasounds are usually normal, or maybe just, they often will describe fat appearance in the liver, but sometimes completely normal. So sometimes though, these folks present with cirrhosis, and looking back, they rule out other types of liver disease like viral disease and autoimmune disease, and they come up with this being sort of the most probable thing for these people. So NASH. Unfortunately, there's not a lot to do to treat it pharmacologically. That's the exciting thing in the liver world. They are coming up with some potential therapies to target this. So there's some promising things close on the horizon, they promise, this weekend. But right now it's lifestyle management. They do know through studies. They've studied this for the past 10 years. It's been the exciting thing in liver disease because they're hoping to make a change in these people's outcomes. But weight loss, what everybody loves, is probably the most effective thing to help change the metabolism in that liver, hopefully to stop that inflammation and that progression to fibrosis and cirrhosis. They've noticed through studies some dietary changes can help. The one I think of the most is high fructose corn syrup. They know there's a direct connection with some of these changes that they see. Regular exercise. If you can't move the scales, at least get your body moving 5 to 7 days a week, 30 to 45 minutes, as much as you can basically, just to change that metabolism. And tight diabetic control. You see a lot of this in diabetics. So again, get their sugars better, get them moving, get them eating better. Those are all so important. So there's no pills. Everybody wants a pill. There's nothing for it yet. But there's some hopeful things. Autoimmune hepatitis. Moving on. An autoimmune disease can affect lots of different places. And of course the liver is one of them. The autoimmune system sort of likes to pick on the liver cells. In this case, you can see some hypergammaglobulinemia. I can't say that word, but some blood tests will show this elevated immunoglobulin G. I've seen this on lots of tests, piecemeal necrosis on the biopsy, sort of a very definitive appearance when the pathologist is looking at it. So in some cases, we just still do use liver biopsy for sort of definitive diagnosis. Often all the other things are negative. You check their viruses, you check their other, hepatitis C, hepatitis B, you check for other autoimmune diseases and they're negative. So it's sort of all points to this. Positive ANA usually, and the ASMA is usually positive in this case. And their immunoglobulin IgG will be elevated, and their transaminases are usually elevated in this case. Treatment for autoimmune. We like to treat autoimmune diseases with prednisone, as you all know. And again, azathioprine we can use for this as well. This will use, usually the combination will induce remission. Can take a while. You might have to treat these patients for 2 years before you can start getting them off some of the medications. Some stay on them, some stay on a real low dose. I have a guy who's on prednisone 5 milligrams and it keeps his liver happy and he's doing okay. So he stays on that. We try to stop it, but it doesn't work. These folks are important to identify. They are important to treat because you can change their outcome. If you can get the inflammation under control, you can slow down their progression to fibrosis and cirrhosis. So it is important to treat these people. They can relapse if you stop treatment. So it's sort of, you got to just watch them. On rare cases, they may need a liver transplant if they don't respond to the medications and the inflammation and things lead to cirrhosis. Hemochromatosis. Hemochromatosis can affect more than the liver, but it is something that I do think of with liver diseases. Genetic disease, genes lead to increased iron absorption in the gut, and the iron likes to stay in the liver for some patients. There are other organs that can accumulate iron too, but the liver is one. Most cases are asymptomatic as well. I've seen these patients come in just due to some routine blood work that's abnormal, and we're trying to figure out the liver part of this. In the past, they did a lot of liver biopsies, but now they have genetic testing for it. There's the two most popular genes that are positive are the C282Y and 63D. You also see elevated ferritin and transferrin saturation, and a lot of times their LFTs will be elevated as well. Usually not sky high, but usually mildly elevated. And liver biopsy is the gold standard before the genetic testing, but sometimes we can get away now without even doing the liver biopsy. If there's possibly overlap with other diseases, we'll still do the liver biopsy to see if there's anything else going on. Treatment, there is treatment. No real cure, but there's treatment. You can do phlebotomy. Sounds sort of archaic, but that is the way we treat hemochromatosis. Watch their hemoglobin, get it into a good range, and their ferritin. End-stage liver disease might need a liver transplant as well. Often in your family history, you'll gather, oh yeah, Dad had something wrong with his liver. And oh yeah, I think it was something iron. A lot of people are more aware of that these days, their family history. Primary biliary cholangitis, PBC, I like to say. It just got a new name. It used to be primary biliary cirrhosis, so if you see that term somewhere, they are the same thing. I think they didn't think people liked the word cirrhosis in their diagnosis, so they changed it. And not everybody has cirrhosis with this, so it was a little confusing. This is a rare disease. Mostly middle-aged women seem to present with it. Again, it's an inflammatory destruction of the bile ducts. You know, we've been talking about the liver and the hepatocytes, but this is actually biliary duct destruction. Their AMA will be positive most often, and alkaline phosphatase likes to go up with this one. So again, you see these patterns that I was talking about. Often they can be asymptomatic, but some will come with those vague complaints of fatigue. Sometimes pruritus, because the bile ducts are affected, so their bilirubin can sometimes go up, which will cause the itching, and jaundice can occur as well, usually with a little more advanced disease. There is a treatment, there's no cure. There's a treatment, ursodeoxycholic acid, and sometimes liver transplant with more advanced disease. This obeticholic acid that I mentioned is sort of newer. It's been around a few years. We don't use it because usually we can get urso for people, but that is an option, which is nice to have options. In the this weekend, they also were saying that there could be some use for this obeticholic acid with NASH. That's one of the ones that's being studied for possibly helping that. So that was exciting. Those are pills you take every day. The urso and obeticholic acid. PSC is super rare. I want you to at least have heard of it because it can affect the liver. It often progresses to cirrhosis. I think my colleague has like 2 patients. We just don't have much of it. Don't know really why people get it. They think it could be more of an autoimmune thing, but maybe some exposure of toxin or a virus. They're not really sure. It's pretty rare. It is interesting. I think it often occurs with ulcerative colitis. I was hearing something this weekend that 80% of people with PSC will get ulcerative colitis. I thought that was an interesting sort of, they're so connected. So if you have a PSC patient, tell them, yeah, you need your colonoscopies. You're gonna have inflammatory bowel disease pretty much. Often we'll use a cholangiography or ERCP to diagnose it. You'll see the stricturing of the bile ducts, string of pearl appearance of the bile ducts. Often 1% cholangiocarcinoma. We have to sort of be aware of that. It's an increased risk. And urso might help, but these patients usually are needing a liver transplant because it usually is more severe. Even after a liver transplant, though, it can recur, which is not great. This isn't really liver disease, but other things can cause your liver tests to go up. So when you're seeing those labs, you can have obstruction. Things that can obstruct are gallstones. They're coming out of the gallbladder, obstructing the bile duct, causing those liver tests to be up. Sometimes you'll see that you might have heard the term sludge, sort of like mud in the bile duct. It can cause an obstructive pattern. Bile duct tumors, you have to think of those. They're rare, but they can happen. And obviously to get rid of this obstruction, you have to remove it in some fashion. We'll talk about that a little bit. So I'll go back to my case. Just to review, a 60-year-old lady with some LFTs, sort of elevated in the past that would get better, presenting with those significantly elevated ALT and AST, and total bilirubin is elevated as well. So y'all probably remember all that. So what are you all thinking? I gave you some choices. Any guesses on maybe what she has has caused her problem? And why?
Hepatitis A.
Hepatitis A? Why do you think that?
She works in schools.
Mm-hmm. Yeah, she might have an exposure there. Around dirty kids, not washing their hands. Any other guesses? That wasn't one of the choices, but it's a good guess.
Oh, I didn't see that.
Any other guesses? It was elevated. It was 4.6. Normal's about 1. It come down a little bit when I saw her. No other brave people?
Epstein-Barr virus?
Okay. I think so.
Because she's with children.
Okay. Another viral might have picked that up from somebody. She did have a positive Epstein-Barr viral capsid antigen IgG, which is more chronic, so it's not acute. IgM might be positive. Any guesses?
Hepatitis.
Nope.
What were one of the options?
Hemochromatosis.
Okay, statin-induced.
Nope.
Autoimmune.
Yeah. It's sort of tricky. It's interesting. She did have the elevated ferritin, because we do see that with hemochromatosis, right? The elevated ferritin. And the iron saturation was really high, so it's a tricky one. And you also saw that the ASMA was positive, 85. I didn't even say it was positive, but it's elevated, 85. Everything else was normal. I listed the abnormals in there. I should have told you that. So it is autoimmune hepatitis because the ASMA is positive, and when you have that much inflammation causing those liver tests to be so high, you often will see sort of a reaction type issue with the ferritin. That'll also go high as well. So when she's having all this inflammation going on, that's bumping her ferritin up too. I would have checked her hemochromatosis stuff as well, but the ASMA was sort of the thing that really got my attention, and she had autoimmune disease. So it's a tough one. It's a tricky one, but hopefully it makes you think about it a little bit. I'm moving on now away from like more of the types of hepatitis to what can chronic hepatitis do to your liver, more to chronic issues, and that cirrhosis. It represents sort of the late stage, fibrosis moves to cirrhosis. The hepatic architecture of, changes, the fibrosis and scarring, and sometimes people develop these nodules as well. You can see those on imaging. It's considered to be irreversible in more advanced stages, where sometimes the only option is liver transplant. In the earlier stages, before you can get to the very end, there is some hope that some of it can be reversed, especially in the NASH world. They were talking about hopefully, with treatment we can change that sort of trajectory for those patients. Often, even like the autoimmune disease and things like that, is so important to treat because you can change, you can slow down, maybe not reverse it, but maybe stop the progression to further damage of their liver. These folks are susceptible to lots of different problems, and it does reduce their life expectancy. Sometimes people present with cirrhosis just on a routine exam. A lot of patients don't go to their doctor very often, and then they'll pop in saying, "Yeah, I've had this. My belly seems to be bigger," or I'm having a lot of swelling and things like that, or I might be yellow. So they're already presenting with problems where it sort of may have been occurring slowly over time, but sort of got just changed. Sometimes we'll find these sort of cirrhotic occurring livers on routine imaging. I've had referrals frequently where people have had a CT for something else and say, "Oh, their liver just doesn't look right. They seem to be fine. They're not having any other manifestations of liver disease, but their liver looks sort of nodular, and maybe see some of these nodules and things like that. So what do you think?" So then we work them up for different types of liver disease. Or they might present to the ER decompensated with ascites or infection or bleeding, and that's sort of the first place we identify them. And some never come to attention. Some risk factors, like we just talked about, are hepatitis, alcohol, diabetes. We're finding is a risk factor for NASH and then cirrhosis. People who use drugs, transfusions a long time ago, family history, the hemochromatosis, things like that. Travel, where they might have been exposed to different diseases or other presence of autoimmune diseases. They like to hang out together. And symptoms, get a good review of systems. That's always important. Sometimes it's pretty vague. You might find on physical exam I've seen some pulmonary erythema before. I've seen that on occasion. I've not seen nail changes as much with cirrhosis, but it is listed as a possibility. Hepatic splenomegaly, you might feel their liver. If you're feeling their liver and feeling their spleen, there's probably something going on with them. You shouldn't be able to feel them, maybe just the edge, but it shouldn't be halfway down their right side. Ascites, they have ascites, you definitely have to think of liver disease. There are other things that cause ascites, but the liver is probably the most common. Jaundice, asterixis. Y'all know what that is from your physical exam? Okay. The flap, yeah. You can see that on patients sometimes. Sort of part of my, just, hold your hands up, let me see what's going on. Definitely hospital patients I've seen it more, the ones that are sicker. They might have completely normal labs. Some people always look at me like I'm crazy if I tell them they have cirrhosis and their lab works normal. But some people can have normal labs, even with cirrhosis. GGT, I don't use GGT as much. Some providers do. It's sort of one of those you can just put all together with and try to find some patterns and changes. That might be elevated. Some folks use that to try to figure out if people are using alcohol. I don't know how accurate that is. Do you use that, Whitney?
Not really.
No. I've seen some providers do that. I'm like, I don't think it's really accurate.
I mean, sometimes, as far as just associating, they're trying to determine if it's alcohol, but
Yeah. I sort of put trends so you can think of those and see if they make sense to you. Bilirubin usually increases with progression of liver disease. Albumin decreases because your synthetic function decreases. Prothrombin time increases because you just don't have those clotting factors because the liver's not healthy. Anemia, lots of things can cause that. Thrombocytopenia, I've had patients refer to me just for thrombocytopenia, and it can be a marker of liver disease. So due to the portal hypertension and the spleen, chewing up all their platelets. Leukopenia, neutropenia, coagulopathies, FiberSure, I mentioned that blood test earlier. I used that probably a month ago to I had a pretty high suspicion this guy had cirrhosis, but he didn't want a liver biopsy. And his liver actually looked okay. It wasn't shrunken and nodular. And I was like, I think you have cirrhosis. So we actually did that test, and I'm fairly certain he does. And he has Hep C, even though he told me there's no way he could have ever gotten that. But some imaging you can use for helping your diagnosis of cirrhosis and managing cirrhosis. I use ultrasound a lot in these cases. In advanced cirrhosis, I think I talked about it might be small and nodular. Increased echogenicity, they describe that a lot. Sometimes with fatty changes associated with cirrhosis. We also use the ultrasounds sort of in our maintenance of cirrhosis patients, where you check that every 6 months in conjunction with another blood test that I'll talk about to screen for liver tumors. I don't use CT much with liver patients. If I'm worried about a liver tumor, I'll move on to the MRI because it's a better test. Better sees those lesions. So, liver biopsy, we did a lot of them before, but we don't do them as much anymore. People with cirrhosis are sort of high risk for bleeding and complication from a liver biopsy, so you definitely have to, is it really worth it? Is it going to change the diagnosis? Is it going to change the way you treat these patients? So you sort of have to use it carefully. It's not necessary if the other things are really pointing towards cirrhosis. But with autoimmune disease, the liver biopsy can, if you're not sure from the labs, if they're a little confusing or not the way you think they would be, liver biopsy can really help clarify the diagnosis. So some complications of cirrhosis. These are sort of what we manage when we have these patients. Some patients do really well, and some people have all the complications. Ascites is one that we see a lot, accumulation of fluid in the peritoneal cavity. It is the most common complication due to the portal hypertension. People are more prone to SVP. These people are sick, they have fevers, they're in the hospital, hopefully. Usually they're having a lot of pain and fever, tenderness, altered mental status usually goes along with that as well. Usually seen towards the end of end-stage liver disease. Hepatorenal syndrome, these folks are sick as well, and this is difficult to manage. I like to use my nephrology friends to help me with this. Because it just gets very complicated when their kidneys start failing and their fluid is overloaded, and it's really hard to get it off without hurting their kidneys more. So it is sort of a diagnosis of exclusion. The nephrologist will usually rule out, other types of kidney disease that could be treated differently, and sort of go from there and just try to manage those diuretics, manage any other meds that could be causing injury to their kidneys as well. It's not a good sign when you start hitting this problem. Variceal hemorrhaging is another common complication of cirrhosis. Due to the portal hypertension, people develop the esophageal varices, and those are pretty high risk for bleeding sort of spontaneously. It can be devastating. People just die of this because they can't treat it effectively enough or quickly enough. But they've had some more modern techniques, and through more sort of proactive screening for these varices, we can hopefully reduce this terrible complication. They can ban the esophageal varices with endoscopy now and make the varices go away. They can come back, but managing the varices better can help. We usually use the EGD. I've never used a PillCam for variceal screening. And then we'll also treat, if we know you have varices, with propranolol just to decrease those pressures and decrease the risk of bleeding. So we've gotten a little better at this, but it can still be pretty devastating in patients who don't know they have cirrhosis and present with upper GI bleeding. Hepatic encephalopathy is a common complication. It changes folks' mental status. They might be very sleepy. They might not be sleeping. They might just not be themselves. And it's due to the ammonia that's elevating due to your cirrhosis and your liver not working well. So you have to manage that carefully. Hepatocellular carcinoma is a risk factor. When you have cirrhosis, your risk of this goes up. It doesn't matter what's caused the cirrhosis, all cases. So we screen. That's why I was telling you, ultrasound every 6 months, along with this blood test, alpha-fetoprotein, every 6 months. Use them together, and they're very good at picking up early, maybe even things you can't see on the ultrasound, and then we move to MRI if alpha-fetoprotein is elevated. So even if you're well compensated and you're doing great, it is a risk, so we got to watch for it. So the prognosis is variable. Folks may do really well for many years, if you can find the cause of their cirrhosis, treat that effectively. Say they have autoimmune disease or this or that, treat their hepatitis C. They might be stable for a really long time, or they might not. So it's just a person-to-person thing. You have to manage those comorbidities and complications. Try to prevent those as much as you can. I put a couple of classification systems up here you might have heard of. Child-Turcotte uses some variables. Child-Pugh. You can sort of predict your survival. You can nobody can predict that, but just sort of give you an idea of, this person has about a 20% chance of being here in 6 months. It can sort of give you an idea, just from different factors. MELD they use a lot for, if we send people to UVA for a consideration of liver transplant, they're going to know what's their MELD, because that sort of puts them into sort of categories as to how urgent is this? Are they going to need a liver tomorrow or next year? And that is changing. It's based on bilirubin, creatinine, INR, and those are all changing all the time. But it sort of gives them some way to classify them. There's some other scores and things you might read about for liver disease as well, but those are the things I think of the most. So the goals of treatment are to, if we can reverse them, if we can treat NASH, we can get them to stop drinking. If we can treat their Hep C, we'd love to slow or reverse as much as we can the progression of their liver disease. Try to prevent, the additional insults they could bring on their liver. Educate them. They've got to stop drinking if they don't know it already. Tylenol, you just don't want it overused. And some of the herbal things, get a good history of what they're taking. Make sure they're not finding all these things on the internet that's going to fix their liver. Make sure you look over those carefully, because people will find lots of good things. Try to prevent and treat the complications quickly. And when is the right time, if appropriate, to send them to talk about a liver transplant. It is the definitive treatment for decompensated cirrhosis. Any other questions? So there's your liver world. I'll take a quick little break and then we'll do pancreatitis. It's short, but I'll just let your brain rest. We'll finish up with some pancreatitis, and then we'll be done. This is really short compared to hepatitis, so. It's not something that I see a lot of in the clinic. People with pancreatitis often present to the emergency room and are hospitalized with acute pancreatitis. Chronic pancreatitis can sometimes bring people our way, but it's not something that I see a lot of, but you should be aware of it. Just a little bit of anatomy. You all know your anatomy, I know, but just the main things we're going to think about today are like the pancreatic duct, bile duct, things that can cause problems in that area. So just think of that. I made a slide of just sort of comparing some things with acute and chronic pancreatitis, things to think about. With acute pancreatitis, you're thinking acute inflammation causing possibly some injury to the pancreas. In most cases, it doesn't progress. The pancreas will get better. Almost always painful. I've never met anyone with acute pancreatitis that didn't have pain. So think pain. Also, you typically see elevations in the amylase and lipase. Those are some big flags for you that it's pancreas. And often will involve a large part of the pancreas, or even the entire pancreas. You'll see that on imaging. Not just a part of the pancreas is inflamed. When you think of chronic, it might be asymptomatic for long periods of time. They may have had acute pancreatitis 20 years ago, and now they're presenting with more chronic picture. They might be presenting more with the pancreas not working well, insufficiency, and they may or may not have pain. Some people can have chronic pancreatitis without any pain, but some other symptoms. They might present as a CT showing a fibrotic mass. They may have normal levels of amylase and lipase. And rather than the whole pancreas being involved, you might see little patches where the pancreas is diseased. So some differences to think of. So I'll talk about acute pancreatitis first. Almost all the pancreatitis I've seen is due to obstruction, where the bile duct or pancreatic duct is obstructed. Gallstones are the biggest cause of this, 35 to 40%. Sometimes the sludge and the small little microlithiasis can cause it as well. Things get backed up into the pancreas and it gets aggravated. You can have diverticula around the ampulla that can cause sort of pressure and put pressure on that bile duct that ends up backing up into the pancreatic duct. That can cause pancreatitis. Tumors, either pancreatic tumors themselves or tumors in the ampulla. IPMNs are another type of little neoplasm that can cause problems with the pancreatic duct, causing pancreatitis. So I just did a little picture in here. This is when I'm talking about the ampulla. This is where it's draining into the duodenum. So if something's getting stuck in this area, it can back up into here and cause things to get mad and angry. So if you don't have an obstruction, another common cause is alcohol. Alcohol does lots of things for what we're talking about today. 30% of cases of pancreatitis are due to just alcohol overconsumption and use. Smoking, they found, can cause pancreatitis. Hypertriglyceridemia, these folks with over 1,000. Think of that as a cause of your pancreatitis. Post-ERCP, if your patient's just had, we'll talk about ERCP in a little bit, they just had this procedure, I can't remember the percentage, I think it's like a 20% risk of pancreatitis afterwards. So when you're talking to these patients about that procedure as well, you have to list that as one of the possible problems that can happen. Hypercalcemia has been related to pancreatitis, genetic mutations, drugs. There's certain drugs out there that you can read and find cause pancreatitis. Some of the diabetic drugs, I think of now that are high on the list, sometimes antibiotics. Infections, toxins, trauma. People have had trauma to their abdomen, they can develop pancreatitis. Pancreas divisum is something you're born with. It's just an altered sort of anatomy. There's several different types of anatomies that can go with that bile duct and pancreatic duct, and that just puts these folks at a little higher risk of pancreatitis. Vascular disease, causing ischemia to the pancreas can cause it. And sometimes we just never know. That throws you in the idiopathic category. So sometimes we never figure it out. Sort of getting a history, they have nausea, vomiting, abdominal pain. Most often it's epigastric. It often radiates to the back. That's classic. Not everybody's classic, of course. a physical exam, you might see sort of a constellation of things with this SIRS, syndrome, the systemic inflammatory syndrome. They might be in respiratory distress. May even have impaired mental status if they're really sick. Their bowel often sort of turns off and is quiet, so they might have quiet bowel sounds or decreased breath sounds. They might be distended. I know y'all love signs. I hated signs because they always put them on tests, but like Cullen sign, you might see that, and Gray Turner sign. Those are some things that you might see somewhere else. Usually these weird echinoses. So always do good abdominal exam, back exam, see if anything shows up there. Some lab things, like we talked about serum amylase and lipase. Lipase is more of my favorite because amylase can go up for other things. You see a pretty significant increase in these folks, greater than 700, 800, 1,000, 2,000, or 17,000 like I saw one time. Triglycerides, you often want to check that, and like I said, over 1,000 makes you really think of that possibility. Calcium, hepatic panel sometimes will be abnormal as well. And if the hepatic panel is abnormal, you think more gallstones because things are backing up into the biliary tree. It may not just be a straight up pancreatitis. It doesn't have to have any liver cause, but often you'll see that with the gallstone issue. Abdominal ultrasound can be helpful. I really like, I think CT is a good test for just if you're just thinking pancreatitis, but the ultrasound will let you see the gallbladder a little better and the liver. MRCP is MRI that just focuses in on the liver and the biliary tree, so if you're thinking obstruction, it's a good test to sort of figure out where that is. Endoscopic ultrasound is sometimes used if you're thinking of tumors and things like that, where they go with endoscopy, an ultrasound probe on the end of an endoscopy scope under sedation and look through the sort of the lining of the stomach. That also gives them the ability to do a biopsy if there's a tumor or a cyst or something like that. So it gives them some ability to do other things. And ERCP, not in defining the reason for pancreatitis usually, but sometimes treating it, if we have to get gallstones out. Managing these acute patients, you might manage their fluid status with normal saline or ringers. Opioids we actually do like to use in this case. It's very effective in treating pancreatitis type pain. Close monitoring nutrition. Pancreatitis patients, you're going to want them to just stop eating, just nothing but mouth for a period of time until their lipase starts improving and their symptoms start improving, and you'll move them on to clear liquids. Sometimes in real severe patients, they'll have to start using the nasojejunal feedings and maybe even TPN in the really sick patients. If there's an infection suspected, of course, you might consider antibiotics. So it's really important to manage the underlying condition if you can figure that out. The ERCP for gallstones, cholecystectomy. If they have gallstone pancreatitis, these folks need their gallbladders out, but probably not while they're acutely sick. Usually you can wait till after they recover to get that gallstone out of there so it stops spitting stones out and causing pancreatitis again. Treat their hypertriglyceridemia if that's the suspected cause. That's important. And treat their hypercalcemia. Here's the ERCP I keep talking about. Endoscopic retrograde cholangiopancreatography. It took me a long time to say that. But it's done under anesthesia. It's a special scope, sort of similar to an endoscopy scope, but instead of what they're looking through being on the end, it's on the side, because they want to get down to this ampulla here, and they actually put a little wire through that. They usually make a little cut to make that sphincter larger, because usually there's something stuck in there. And then they put the wire in and they sort of look at this anatomy here, look at the pancreatic anatomy with some dye, and then they find that stone or obstruction and they put a wire past it, blow up a little balloon and pull it out, so they sort of sweep it clean. You can imagine that might cause the pancreas to get aggravated, just manipulating all of that. So that's why the pancreatitis is a big risk factor after ERCP, but sometimes it is needed to get rid of this obstruction. So it's like cause one problem, solving another, but that is a common procedure they use to identify those obstructions and get them out. If there is a tumor there, that is another way to get a biopsy of a tumor that would be in that area. You can biopsy that. So, acute pancreatitis complications. Some things that can happen afterwards are some fluid collections, pseudocyst formation. They're not the classic cyst, pancreatic cyst, but that's why they're called pseudocysts. But they're a complication of having all that inflammation. You can develop necrotic collections as well, sort of walled off necrosis. These areas are sort of nasty and will need to be treated. We send folks to UVA for that type thing, where they have to sort of go clean all that out, sort of surgically. They actually have some new techniques where they'll tunnel through the stomach to get to those collections and sort of go that way rather than an abdominal, open in the abdomen. But infected necrosis can make you die. It's pretty bad stuff. So they're not that common, but definitely you got to watch for those. I like to give you differentials, things to think of otherwise. It may not be pancreatitis, but it can act like it. You can have perforated viscous, like a perforated ulcer. Amylase will often be elevated, so that's why I use amylase and lipase with perforated ulcers. You can see that. It can act a lot like pancreatitis. Cholecystitis can act a lot like it as well. Bowel obstruction, renal colic, MIs. If you have this pain all here, it could be your heart too. Pneumonia, ketoacidosis, I've listed duodenal ulcer there too. So moving to the chronic realm, it's more of a progressive sort of, we talked about liver disease can sort of move through inflammation, fibrosis, and then cirrhosis. It's I sort of think of it the same way, where you develop sort of this chronic inflammation, moves on to fibrosis, and sort of scarring of the pancreas that results in permanent damage and structural changes that then is going to affect, its exocrine and endocrine function. So that'll make sense when you start seeing the things that it can cause. Again, alcohol is the big thing with chronic pancreatitis. It's the most common by far. Genetic causes, you often hear cystic fibrosis patients having pancreatitis involvement. Ductal obstruction, that pancreas divisum thing you see again, sort of just an anatomical change. Stones, tumors. I haven't seen that cause chronic pancreatitis much, but it's listed. Tropical pancreatitis is on the list. I don't know what that is. Systemic diseases like lupus, hypertriglyceridemia, I keep coming back to, those can cause the chronic issues. Autoimmune pancreatitis, I think there's an autoimmune disease for every organ. So of course pancreatitis can be autoimmune as well. Very rare. Seen it once in 14 years. Idiopathic pancreatitis, that's what we don't know what it is. Manifestations, you can have pain. Like I told you in that one of the first slides, you may not have pain. If you do, it's usually epigastric again, sort of like the acute pancreatitis pain. And often it's worse after they're eating. It might be related with some certain position changes. These folks will be like, I'm just comfortable if I can sit up, and I like to lean forward, and it sort of just makes it stop hurting. I think it's just all the inflammation involved. You can have the signs of pancreatic insufficiency. The fat malabsorption, causing steatorrhea, and diabetes. I mean, they can become insulin dependent because they're not having their endocrine function, and they can also have hypoglycemia too because of the glucagon producing cells being affected. These folks are challenging. Sometimes they're challenging just to diagnose because their labs are normal. If their imaging is normal, it's really challenging. I had a guy just like 2 months ago who had given me this great story of this pancreatitis like 5 years ago, and he's had sort of this recurrence of pain. His imaging is completely normal now. There's no evidence of changes on the imaging, and his labs are fine. He has a good story though, so I think he does have chronic pancreatitis, but it's just really hard to define. He has good times and bad times. Usually he can get through his little spells by drinking clear liquids for a week, and then he's fine for another 6 months. So it's a tough one to define for him. But anyway, that's just one I think of because his labs are normal and his imaging is normal too. So I'm like, sounds like pancreatitis, but I really can't say for sure. Because he doesn't have the calcifications. He does have some intermittent bowel changes, but not straight up steatorrhea. His stool studies, we'll talk about those, were normal. So it's sort of a difficult picture. The stool studies you can use for the steatorrhea to see if it's more of the fat malabsorption problem is a 72-hour quantitative fecal fat. People really love you when you tell them they need to collect their stool for 72 hours. It's a fun one. The fecal elastase has become a better, easier for patients. They don't have to do that for 72 hours. So that's sort of going more towards the more recommended test. You can do some abnormal secretin function tests that can be abnormal with these chronic pancreatitis patients. And always think of autoimmune disease. You can check the IgG4 immunoglobulins, and that can suggest the autoimmune cause. MRI is really the best imaging choice for chronic pancreatitis. The ultrasound and CTs just aren't as good. We don't use the RCP for diagnosis of chronic pancreatitis, but endoscopic ultrasound might be useful to get sort of a different perspective looking at that pancreas. Something to consider. Other differential, when you think chronic pancreatitis, make sure they don't have cancer, autoimmune, lymphoma, and the endocrine tumors can sort of act the same as chronic pancreatitis. Again, treatment is manage their symptoms. We're trying to get away from opioids, but they are effective in this class of patient. They're tough to treat. A lot of them become narcotic dependent, unfortunately. I've sent some to pain management just because, I think they should be treated. They do have issues, but it is a challenging set of folks. There's been some success with some amitriptyline and nortriptyline, using that maybe in conjunction with opioids to treat their pain. They've got to stop drinking. These are anti-drinking lessons for hepatitis and pancreatitis. Decreases their symptoms significantly and decreases, their mortality. They should stop smoking as well. So it's two hard things to stop, but really important. They found that it may slow their progression to more scarring and complication. Watch out for diabetes. These folks are probably going to be diabetic if they're not already, and that needs to be managed appropriately. Sometimes lifestyle measures, trying to, like my guy who goes to his clear liquid diet, and he knows what he has to do. Clear liquid diet, if they're really having symptoms, can help. Low fat diet can help. Just take some of the pressure off of the pancreas that's struggling to keep up. That can make a difference. But these folks are also the ones who can't maintain their weight because they can't eat anything and they're in pain. So it's tough when you tell them to eat small, low-fat meals. Good hydration. Sometimes if they have autoimmune disease, the steroids again are the treatment of choice, maybe with azathioprine as well. You can supplement them, for those with weight loss, with those triglycerides. Also, sometimes people find a lot of benefit from the pancreatic enzymes. Giving them the things they need to help their digestion can make a difference, decrease their pain, help their steatorrhea. So there's some options out there available for that. The celiac nerve block is a couple of patients I've sent to the pain clinic. They can actually do a block on that celiac nerve and help decrease their pain and make their quality of life better. Surgery, typically, sometimes if you have like something that's possible cancer, they might need surgery. Sometimes large cysts, pseudocysts might need to be surgically taken care of, but question marks because maybe not. So, and that's it. That was short. Any questions about that? Just email me if you have questions. If y'all have any suggestions of things that would make the topics better, just let me know. I'm always open to suggestions. I want to make these the most helpful for you guys. I just want y'all to take away things that you can take into your rotations, actually study up on before you go to your GI rotation and sort of know what's going on.
If you treat somebody who has severe cirrhosis and hepatitis C and give them the antiviral and cure them of hep C, how is their recovery after that?
It can make a big difference. They are recommending treating everyone with hep C. In the past, these decompensated, really sick cirrhotics, they would say, how's that going to affect their, future? But they're finding even treating the sickest of sick hep C patients now that it helps them. They sometimes have a slow down for their progression of their disease, might slow their cirrhosis changes, might help them have a better quality of life, might do better, might make them be able to make it to a liver transplant, where before they were so sick they weren't even a candidate. Oh, that's another cool thing. With hep C treatment now, liver transplant is sort of excited because now you can transplant hepatitis B positive livers in folks and then treat them for their hep C. So there's going to be a lot more livers available, which is exciting. Because before you'd be like, I don't want a liver with hep C in it. but now it's going to be a possibility. So that's sort of exciting. So treat them. Always treat them. I have a lady who's is sort of decompensated, and she was treated with one of the newer meds, but then she failed. She responded, but then 6 months out, her Hep C was back, and so I was like, well, that's sort of weird. She had all these genetic mutations that made her more difficult to treat. The folks over at UVA told me, and so they're treating her again, and we're hoping to get her to where she can be good enough that she could have a liver transplant too, so get her more stable. I'm hopeful for her. But they also told me when she gets insurance, send her back. I was like, what? She doesn't have a job because she's disabled from her disease. And I'm like, why would you need insurance to get a liver transplant? But that was sort of unfortunate. I don't know all the situations of the insurance and what's required, but anyway. If you have questions, let me know, okay? Thanks for listening.